Continue with our presentation. So now we'll be focusing on unconjugated, the causes of unconjugated hyperbilirubinemia, and we'll be looking at each of them in detail with particular attention to the most common and the most critical ones for exam, from the exam point of view as well. So we're going to start off with the hemolytic causes of unconjugated hyperbilirubinemia. Here we have a few categories. We can divide them into three. You have causes outside the red blood cell, within the red blood cell membrane, and within the enzymes of the red blood cell. So we have RBC antibodies, RBC enzymopathies, and membranopathies. We're going to start off with the antibody issues. So we have ABO incompatibility. I think most are familiar with this. But blood group incompatibility occurs if the mother's blood group is O and the baby is either A or B. So we'll see in the coming slide that the blood group O carries antibodies to A and B antigens. So an IgG, anti-hemolysin A or B antibody, will develop in the maternal circulation and cross the placenta to break down the fetal red blood cells. So this is important to remember. IgG is the type of the antibody that is able to cross the placenta. And apart from the ABO incompatibilities, which is major blood group incompatibilities, even minor ones like Kell or Duffy antibodies can cause incompatibility between the mother and the baby. So like we discussed that the blood group O has antibodies to anti-A and anti-B in the plasma and has no antigens of its own. So it's very important to remember that the mother's blood group should be O and the baby will be either A or B. When it comes to Rh incompatibility, it's a much more serious disease as compared to ABO incompatibility in the neonatal period. Usually, in modern days, Rh incompatibility is diagnosed by antenatal screening. So, what exactly happens in Rh incompatibility? If the mother is Rh negative and the baby is Rh positive, because the baby's father is positive, this can lead to an incompatibility and it will lead to destruction of the baby's red blood cells, causing severe fetal anemia, hepatosplenomegaly, ascites, and even hydrops, which can be fatal to the baby. We'll see in the next picture how exactly that looks and what happens. But the most common triggering antigen is the capital D antigen. So anti-D, usually they say anti-D immunoprophylaxis is required in the mother. So try to remember the capital D letter. And these antibodies are also of the IgG type, like the same ones in the ABO incompatibility. So they can be transported across the placenta and delivered to the fetal circulation. So see here in this picture, we can see that in the picture on the left, the mother is Rh negative and the baby is Rh positive. So you can see in the side picture, there's no way that the baby can be positive if the mother is negative unless the father is carrying the positive Rh antigen. So the Rh negative woman will receive some of the baby's Rh positive antigens in the circulation. This will cause some antibody formation, and these antibodies can pass to the baby. So what's critical to remember is that Rh isoimmunization will have a major effect on the second pregnancy, because in the first pregnancy, the mother has not been exposed to the Rh antigen previously, unless she had a miscarriage before, she had a blood transfusion, or she had some kind of surgical procedure during her previous pregnancy, or during the miscarriage treatment, which caused some hemorrhage of the previous baby's blood cells or any other source of Rh antigen into her circulation. So the most common scenario will be that the mother in the first pregnancy has not yet been exposed to Rh positive fetal blood cells. So the first baby will usually be born completely normal and unaffected by this. But the hemorrhaging during delivery and during the course of pregnancy will create autoantibodies within the mother towards the Rh antigen. When it comes to the second pregnancy, if the second baby is Rh negative, then the IgG antibodies from the mother's circulation will cross over into the baby and create problems like we mentioned: hemolysis, anemia, ascites, hydrops, and it can even cause fetal death. So now, clinically, if you have a baby with jaundice and anemia, how would you know if they're having an Rh incompatibility or an ABO incompatibility? Apart from blood test, of course, the key clue is first whether this is the first baby or a subsequent baby. Usually, Rh incompatibility will come on the second baby, and ABO can come in the first baby as well. And the severity is a major red flag. So if the baby is very sick, they have severe jaundice, very bad kind of anemia, they are symptomatic, tachypneic, tachycardic, unwell looking baby, there's a much higher chance that they are having Rh incompatibility. Whereas ABO incompatibility is usually milder, and the immune testing, which is the DAT test, will be strongly positive in Rh incompatibility, and it can even be negative in ABO incompatibility. So it's quite an interesting phenomenon, and it happens because in the fetal red blood cell, there are fewer group A and group B antigen sites than the Rh antigen sites. So if there's a sensitized A or B cell in the baby's blood, it will usually survive longer than if there are anti-Rh antibodies present. Now let's move on to the red cell membranopathies. So in red cell membrane defects, the most commonly asked disease and most common out of all of them is spherocytosis. So these are and other causes are eleptocytosis, pyropoikilocytosis. These are all autosomal dominant defects in which there is something wrong with one of the proteins in the red cell membrane. So this will make the red cell shape much less deformable, and it will be easily destroyed in the splenic microvasculature. These are some examples. So we can see, starting with the spherocytosis picture, what is a spherocyte? So the red blood cell will look very round and it will be full of this red color. So usually a normal red blood cell has some central clearing, but a spherocyte does not, and it is not in a sort of ovoid shape. It will be a perfectly round sphere kind of shape. Now coming to the eleptocytosis, you can see that the red blood cells start looking like a tube kind of picture. Stomatocytosis, stoma is refers to like a mouth kind of opening. So the RBCs look like they have a mouth kind of shape, if you can notice in the blood film. And poikilocytosis, you will find broken kind of irregularly shaped red blood cells present. But from an exam point of view, I would say that spherocytosis is the most commonly asked, or one of the most commonly asked, because it's very easy to pick it up. So this slide is here just for personal interest. If anyone wants, you can pause on the slide and have a look at the different kinds of red blood cell shapes that you can find on a blood film. But as I mentioned, that from an exam point of view, you should be very well versed with spherocytosis. So let's talk about spherocytosis. We mentioned in brief that when you have a red cell membrane defect, this means that there is loss of the stability of the red blood cell, reduced deformability, which is present in a normal red cell. So this will result in trapping in the spleen microvasculature, and the red blood cell will get broken, and then eventually it will get phagocytosed and then taken in by the white blood cell. A clinical tip here is that when you do a blood film, you can find spherocytes not only in hereditary spherocytosis but also in autoimmune hemolytic anemias. So, how do you tell the difference between a hereditary spherocytosis and autoimmune hemolytic anemia? It will be using the Coombs test, which will be positive in an autoimmune disease. And let's say you have a baby with jaundice. How can you tell if, how will you get a clue that it's spherocytosis before doing any tests? A family history of jaundice and early splenectomy is very suggestive of hereditary spherocytosis. As we mentioned, it's an autosomal dominant disease. Alright, and now we come to the RBC enzymopathies. The most common, which I think you would be knowing, is G6PD deficiency. So, G6PD deficiency is an X linked recessive disorder, and this is a disorder that leads to oxidant induced red cell hemolysis. There are a lot of enzyme variants, over 400. So the main issue in G6PD deficiency, as we'll see in the coming slide as well, is that there will be intravascular hemolysis causing a rapid drop in hemoglobin, and usually this will present in an older baby with fever, malaise, dark urine. And once the child is out of the acute hemolytic crisis, you can measure the enzyme level for confirmation. So here we have a G6PD deficient red blood cell. There will be oxidative denaturation of the hemoglobin because the function of G6PD or glucose 6 phosphate dehydrogenase enzyme is to prevent the oxidative damage to the cell. So if this enzyme is deficient, the red blood cell will undergo denaturation of the hemoglobin. The membrane bound precipitate will get deposited, and this is called a Heinz body. So this is the denatured hemoglobin that kind of clumps into something called a Heinz body, which is the blue dot which you can see in this red blood cell. So this Heinz body will damage the red cell membrane and will cause an attack by the macrophages in the spleen. So this will result in white cells, and if it's less severely damaged, even in this case, you can find spherocytes. So you will find white cells, you can find blister cells, and from an exam point of view, and they might bring you a blood film. So even a Heinz body suggests that there is denatured hemoglobin present there, which can happen in G6PD deficiency. Now, something very interesting, we mentioned that G6PD deficiency is a X-linked recessive disease. So that means that it will most commonly be present in boys. But what about females? Can G6PD deficiency affect a female? The answer is yes. So how does that happen? If you see on the rightmost side, if you have a female with both X chromosomes carrying the deficiency of G6PD enzyme, so the mother has one X chromosome or two X chromosomes which carry the deficiency, and the father is G6PD deficient as well. So the daughter will have manifestations of the deficiency as well. But if you have a heterozygous female, you would expect that she's not going to present with the disease. But in rare cases, if she has skewed inactivation of the X chromosome or selective inactivation of the healthy X chromosome, so a female has two X chromosomes, right? If a heterozygous female is present, so she has one normal X and one X chromosome with the deficient G6PD enzyme, the G6PD deficient gene. So if the G6PD deficient chromosome X gets more activated than the other X chromosome, then she will be carrying the she will be presenting with the disease. Another red cell enzyme defect, which I won't be talking about in much detail, is pyruvate kinase deficiency. It's less common than G6PD deficiency, and it can be associated with an aplastic crisis and severe persistent hyperbilirubinemia. It's quite rare. I've only seen one patient with that, and they rarely ask about this disease in the exam, except for the fact that you should know that it's similar to G6PD deficiency in that it's an red cell enzyme defect. Hemoglobinopathies like thalassemia, they can also present with jaundice due to hemolysis. So why does that happen? I think the picture in the next slide will explain it very clearly. But if you remember the pathophysiology of thalassemia, you will know that there is an excessive buildup of unpaired globin genes, either alpha or beta, depending on which type of thalassemia it is. So this will precipitate in red cells as inclusion bodies, kind of similar to the Heinz bodies that we discussed for G6PD deficiency. So these inclusion bodies are abnormal presence within the cell, so they are toxic and they will be destroyed in the bone marrow and the spleen, hence causing hemolysis as well. So if you see in alpha thalassemia, there is excess presence of beta genes, and in beta thalassemia, there is excess presence of the alpha chains. So these will get precipitated, deposited as inclusion bodies, and they will subsequently cause the red blood cell to become hemolyzed. So that was it for the hemolytic causes of unconjugated hyperbilirubinemia. So just remember that picture of the red blood cell, which will help you to remember the different causes, because there is 100% you will be asked about these causes, and you should be able to enlist them and clearly explain each of them. Let's go to the non-hemolytic causes. Breast milk jaundice. So this is a very interesting disease in which the breast milk itself is the reason for the baby to have jaundice. So there are certain enzymes in the breast milk that can be present, which will inhibit the bilirubin conjugation. Usually, this develops in the first to the second week of life. It will not be present immediately after birth. Usually, if breastfeeding is interrupted for 1 to 2 days, it will result a decline in the level. But with breast milk jaundice, it will never cause a very high level of unconjugated hyperbilirubinemia that can negatively affect the baby. And interestingly, if you have interrupted the breastfeeding and you restart after a few days, the jaundice will not develop again. There are a lot of theories as to why breast milk jaundice happens. The most common is that there's a certain kind of mutation in the enzyme which will within the baby itself, which leads to a delay in the conjugation of the bilirubin, or there's an increased activity of beta glucuronidase in human breast milk. Polycythemia is also a cause of unconjugated hyperbilirubinemia, simply because you have an excess number of the red blood cells. So once they get broken down or their natural lifespan is finished, the amount of bilirubin that's being produced is far too much for the baby to be able to conjugate effectively. The most common cause is infant of diabetic mother, because they will have high erythropoiesis due to chronic hypoxemia, which is associated with the hyperinsulinemia, hyperglycemia, hyperketonemia. If you have a baby that's small for gestational age, they will also have high erythropoietin. If you have delayed cord clamping, this will increase the fetal hematocrit, and this can also be dangerous. If you have twin to twin transfusion syndrome or neonatal hyperthyroidism or any kind of trisomy, the most common 13, 18, and 21. This is a picture of twin to twin transfusion syndrome. You can see the recipient twin is much pinker than the donor twin. It's a rare complication, but it can happen in twin pregnancies. Another cause is hemorrhage. So you can see in this picture that the baby is having a hematoma formation on the scalp. So these can happen because of birth traumas. And rarely there is a condition called isoimmune thrombocytopenia, and which is in a way similar to the RH incompatibility. However, you can say it's the platelet version of that disease. So, in a similar fashion, the platelets will be destroyed, the fetal platelets, and this can increase the risk of bleeding. And finally, we come to the glucuronide transferase enzyme defects. So, we know from our previous presentation that glucuronide transferase is the enzyme present in the liver, which is responsible for conjugation of the bilirubin. So there are three main things that can happen. The two main ones which I want to emphasize on are Gilbert syndrome and Crigler-Najjar syndrome. Both of these are diseases of the same enzyme. Hypothyroidism, it's a systemic disease. So there's nothing wrong with this enzyme per se, but because severe hypothyroidism affects all the enzymes and all the systems of the body, it will similarly slow down the activity of glucuronide transferase, resulting in jaundice for that reason. But I want to pay particular attention to the first two diseases which we have mentioned, and it's really important that we retain this information, especially for the exam point of view, because clinically they're both quite rare. So what is Crigler-Najjar syndrome and what is Gilbert syndrome? Crigler-Najjar is a very serious disease in which you have two types. So you have type 1 and type 2. In type 1, you have absolutely no glucuronide transferase enzyme activity, which is, of course, uh, a very serious and major issue. Type 2, you have very low activity below 10%. So this is also a very serious condition. Gilbert syndrome, you have reduced activity, but the enzyme is still present and it's working well. So if the child is in a baseline state, normal physiological state, Gilbert syndrome will not cause any kind of symptoms in the baby. But as we said, Crigler-Najjar is a very serious, rare autosomal recessive condition, and this will usually lead to kernicterus in the baby or brain damage because the unconjugated bilirubin will go to very high levels. And if you have type 1 in which there was no enzyme whatsoever, till date there's no enzyme treatment for this condition. So it will result in severe hyperbilirubinemia and kernicterus, as we'll discuss it further on. Type 2, you have some residual enzyme activity, as we said, less than 10%. So studies have shown that phenobarbital induces this enzyme activity. So it's worth a shot to give this a kind of patient phenobarb. Now, Gilbert syndrome, it actually shouldn't be present in this in our topic of discussion of neonatal jaundice, because Gilbert syndrome does not usually present in the neonatal period because it is so mild, and the level of unconjugated bilirubin does not usually reach the treatment threshold. So why does this condition happen? We mentioned that there is a mild enzyme deficiency. Usually the child will present in the teenage years because the during puberty there is a higher hemoglobin turnover, and the sex hormone production will inhibit further the bilirubin glucuronidation. And why do they come? They can come for any reason. Let's say the child comes for a fever and a cough unrelated to Gilbert syndrome, but the doctor does a few extra blood tests. He will find that the unconjugated bilirubin is elevated. Or the child can have mild recurrent episodes of jaundice. So his friends might say, hey, you look like your eyes are yellow. So, he might go to the doctor for that reason. But as such, the disease is very strongly contrasted to Crigler-Najjar syndrome, and no treatment is required in this condition. And interestingly, patients with Gilbert syndrome concurrent with G6PD are susceptible to prolonged neonatal jaundice. So that's one caveat. So you can have a neonate if you have that rare off chance that a baby is having both these conditions, G6PD deficiency and Gilbert syndrome, they will have prolonged neonatal jaundice. So this slide is just for revision. So Crigler-Najjar is thankfully autosomal recessive. So you can remember it as it's very severe, almost fatal. So we're hoping that it's autosomal recessive as compared to Gilbert, which is less severe, so it's autosomal dominant. That's one way of kind of remembering it. And we discussed the other points as well in regards to the probability of kernicterus. So it's the highest in type 1, almost certain to happen. Type 2, because you have a treatment and also the level of the enzyme deficiency is not that bad, so it's rare to go towards kernicterus. But for Gilbert syndrome, it will never happen. And the response to barbiturates is good for Crigler-Najjar and Gilbert syndrome, as this medication will stimulate the enzyme activity. The only treatment for Crigler-Najjar type 1 is a liver transplant, because we mentioned that glucuronide transferase enzyme is present in the liver. For type 2, we mentioned about phenobarbital, and liver transplant can also be done. And Gilbert syndrome does not require any treatment. So we'll finish off this presentation with a spot diagnosis. So this is critical to know for when we're studying about unconjugated hyperbilirubinemia. Why did we start off with unconjugated rather than conjugated? Because as we mentioned in the first part of our topic presentation, that unconjugated bilirubin crosses the blood-brain barrier and it will lead to this condition. which is kernicterus. Kernicterus is unconjugated bilirubin encephalopathy, which happens when the indirect bilirubin concentration will exceed the albumin binding capacity. This toxic, poisonous indirect bilirubin can deposit in the brain cells, especially in the basal ganglia, and this will cause disruption of the neuronal metabolism and function. Usually, it can develop when the bilirubin level exceeds 25 in term infants, and if the baby is preterm or with a low weight, it can happen at an even lower bilirubin level because prematurity will increase the blood brain barrier permeability. But they can say that this kernicterus can happen at any elevated level of unconjugated hyperbilirubinemia. If you have a baby with the unconjugated bilirubin reaching the treatment threshold, we should start the treatment immediately rather than waiting for it to reach the 25 and then we start being concerned. So we mentioned this point that kernicterus can develop at even lower levels of bilirubin in a baby who's premature or with a low birth weight or a generally sick baby. A generally sick and unstable baby does not have the same resilience as a baby who is healthy and term. So if a baby is septic, meningitis, if they have hemolysis, hypothermia, asphyxia, if they are hypoxic, so these conditions will further reduce the threshold as they increase the blood-brain barrier permeability and increase the chance of the baby going into kernicterus. How does a baby present? The early features will be a very irritable baby with who's tired, having poor feeding, vomiting, hypotonia, poor Moro's reflex, and high-pitched crying. And this usually develops by the fourth day of life, by the time the basal ganglia is very much affected. Late features after which usually the child does not survive. They will go into fever, hypertonicity as compared to hypotonia in the earlier stages. Anterior fontanelle will be bulging. The baby will have opistotonic posturing, which is a very hyperextended back and hyperextended arms and legs, as we saw in the picture earlier. Paralysis of upward gaze, seizures, pulmonary hemorrhage. If a child crosses this stage, then they will have residual nerve deafness and the special type of cerebral palsy, which involves primarily the basal ganglia, which is chorioathetoid cerebral palsy. So, this is also very important to remember as it's a common exam question that kernicterus will lead to chorioathetoid cerebral palsy. They can have enamel dysplasia and discoloration of the teeth. So that's it for this presentation, guys. We'll move on to conjugated hyperbilirubinemia in the next presentation. Thank you so much for watching.